Today, we focus on a subject at the very heart of healthcare delivery, maternal health. We are beginning with an often overlooked stage, which is preconception. I'm your host, Julius Mugisha, Head of Marketing and Communications at Nakasero Hospital. And I'm glad to be joined by Dr. Emma Amadrio, our resident obstetrician and gynecologist. You're welcome, Dr. Emma.
Thank you. Thank you for having me.
Dr. Emma, could you start by telling us about yourself and the work that you do at Nakasero Hospital?
Okay. Thank you. My name is Emma Amadrio. I'm an obstetrician gynecologist. So an obstetrician is a doctor that specializes in women's care, specifically around pregnancy and childbirth. And a gynecologist is that doctor that manages the reproductive system of a woman. So in Uganda, we mostly are obstetrician and gynecologists. So that is my specialty.
Fantastic. To begin with, what is preconception care?
Okay. So preconception, the word preconception, means before conceiving or before pregnancy. So that's what preconception is. Preconception care is care before you get pregnant or care before you conceive a pregnancy. So in this case, by WHO standards, WHO is the World Health Organization. So by WHO standards, preconception care is the care that we give, the medical care that we give to a couple. That is a man and a woman, a couple, as by our country, a couple that has come to us and they intend to have a child or intend to have a pregnancy. So this is care that we give them to optimize their health. And this can be in the biomedical, that is in the medical, the things that we call health-wise, and the behaviors that they have, so the behavioral aspect and the social. So we have to optimize all those three areas to see to it that they have good outcomes for the mother and the baby. So that is preconception care in a nutshell.
That's fantastic. That's fantastic. Now, we've had maternal health with us from ancient times. We've known about, we've had mothers deliver babies, we've had children. Why is it so important now in 2025 to be talking about preconception care?
Okay. Yeah, maternal health has always been with us. It's a spectrum of things, right from antenatal care, labor and delivery, to postnatal. Postnatal is after delivery. So a number of things are done along this journey. If you recall, Uganda has had previously a high maternal mortality rate. We were at around 336 deaths of mothers per 100,000. So that's a ratio. High, yeah. And now with interventions in maternal health by our Ministry of Health, we have brought that number down to 185 per 100,000. So a lot of interventions have gone into maternal health. You hear us talking about campaigns by the Ministry of Health in things like bleeding after delivery. There are campaigns running called PPH. There are campaigns running about preeclampsia, that is hypertension in pregnancy. So we always have things running around maternal health because we want to improve things that cause challenges for women. And we've seen significant improvements channeled by health workers, by Ministry of Health, by WHO, and we have seen those things improve. Mothers are better, mothers are healthier. But now, why are we talking about preconception care? We have noticed that most women or most couples are having children at an older age than before. And this is not really a bad thing because we are focusing more on careers, we are focusing more on our finances and trying to see that when we have families, we are able to afford those families because economic times have changed. You know, the last time when our parents would do so much with 50K, now you have 50K and in one day it's over. So we want to plan better for the families that we are going to have, meaning most couples are going to have children later. What does this pose? It increases the risks for children with congenital abnormalities, the risks for preterm labor. We have seen preterm labor also on the rise. And you notice that the Ministry of Health is putting up neonatal ICUs all over the country to manage preterm babies because those babies are more. So such challenges come in, and preconception care is key to see that the couple is prepared in their health status. Whatever conditions they have before they get a pregnancy are managed and controlled so that we don't have such challenges when they have their pregnancy and carry their pregnancy to term. We have a baby who is healthy. In the year 2000, Uganda had a fertility rate of 6.7, meaning every woman had averagely 6 children, 6.7, let's say 7. But at 2004, it's estimated to be 4.5, meaning the number of children that each woman may have has reduced. So the children that we are having are also fewer these days. So we want to have children who are well, because we don't have the luxury to have 12 children. Yeah.
Fantastic. And again, it is having children that are having challenges that are going to make it even more expensive to manage the kind of
that's
family.
True.
So, I mean, the lifestyle has changed, definitely. At what point should this kind of care begin? Because they are career women, they're working, they're young women out of school, they're starting families. At what point should this care ideally begin? At what point should I knock on the doctor's door to say I'm now ready?
Okay. So if a couple is planning to have a child, we usually advise at least 3 months before conception to visit their gynecologist and have preconception care screening done for them. And for some conditions, we even encourage this before a couple thinks about getting married. There are some conditions that we may want to screen at that point before getting married. But commonly for preconception care, we are really looking at 3 months before conception, 3 months before getting a pregnancy. So that is optimal time for the things that we would want to do for this couple. So that's the time we would give.
Thank you, Dr. Emma. We are now going to dive in. Our listeners, our viewers want to understand this preconception care to its depth. What is involved in this? How long does it last? What is involved? What do I need to do as a young couple? How do I prepare for it? What is involved in preconception care from the perspective of the obstetrician?
Okay. Yeah. So according to WHO, we have 3 areas that we need to focus on for preconception care. So I mentioned the biomedical. So biomedical, I'll try to break it down and make it a bit not as medical English. So in the biomedical field, we are really focusing on the conditions or infections or diseases that a person may have. So we screen for infections, we screen for genetic disorders that could be there. We screen for what we call NCDs. Those are non-communicable diseases like diabetes, hypertension. So we screen the couple for these things, and we look at how those conditions are affecting their lifestyle and see that we manage those conditions. There are those that are treatable and they will be treated to remission, meaning they are treated and they heal. There are those that cannot be treated to go away. The commonest example we have is HIV. We may not treat HIV to take it away. We are going to treat it to be undetectable. That protects the child that is coming. Hypertension, we treat and make sure that blood pressure is well controlled before the pregnancy. If there's diabetes, we treat the blood sugars, what we usually term it as, and make sure that it's well controlled before a pregnancy comes in. So that's one of the biomedicals.
So that's screening.
Yeah, screening. Okay. The other is medications. A number of us may be on medications for different things. Now, some medications are not safe for the baby inside the mother's womb, especially in the first trimester. So it's important for your doctor to look at what drugs are you on. Are they toxic to the baby? that is growing within you. So if those drugs have potential to be toxic to the baby, then we look for the alternatives to those drugs. And if those medications were given by a different specialty, let's give an example, if they are given to you by a physician, we are probably going to send you back to the physician with a request for them to get you an alternative drug to use that is safe for pregnancy. So we have to manage your medicines that you're on. That is another important factor that is in the biomedical. As well, in the biomedical, we look at optimizing your health. So vaccines come in at this point. There are things that we want to vaccinate for, but these vaccines may not be safe in pregnancy. So we have like the rubella vaccine, the influenza vaccine that we give to women, but we want to give these vaccines before we conceive. So that is in the biomedical mostly. And then we also have the second category, that is the behavior. So in the behavior, we are looking at what are your habits, what are your hobbies. Are these habits or hobbies safe for a pregnancy? Lifestyle, really. We are looking at lifestyle. So we look at what does this person do, where do they hang out. Sometimes we have people using particular substances and they're taking alcohol or they are smoking. So we are looking at those things that, you know, your behavior that you're engaging in. And we may want to help you reduce on those. And when we come to substance or drugs of abuse, those are not safe for our babies. Alcohol is not safe for our babies, especially in the first trimester. And maybe to give you a side note, most people don't realize that they have conceived a pregnancy. And yet, the first 3 months of a pregnancy is when all organs are formed. So when you don't know that you're pregnant, in the first 3 months, you're still taking alcohol, you're still smoking. By the time you realize that, hey, wait, I'm pregnant, what we needed has formed and maybe formed with problems, but they've already formed. So the first trimester is key, and that's why we are saying we start from preconception. When you conceive, our baby is healthy and good.
I thought you're actually able to tell you're pregnant even in the first few weeks.
Not all women. Not all women tell that because there are things, they may have some bit of spotting sometimes in the first trimester that confuses, is this really a period? Is not. So there are times women find out they are pregnant, especially those who are not intending to get pregnant, and come for a pregnancy test when it's 2 months, that's around 8 weeks or 3 months. But we have missed that window of optimizing for this child. And if you've been engaging in drugs or medicines that were not safe, mostly as health workers, we are just going to observe and see what happens, because we can't reverse time. We will observe at that point. So that's the second aspect. The third aspect is the social. So pregnancy is it has a lot of hormones going up. It's an emotional state. There's a lot of need for social support. So we talk about, who is supporting you. We discuss with you the support we think you need. We also look at what is your job, your work area. Some of the work areas we go to may not be safe. So, for example, if a health worker that works in a radiation unit, if she got pregnant, that's maybe not a unit that she should work in, because the radiations are dangerous to the baby. So those are the 3 broad areas for using our WHO standards. And those are the things that we'll be doing for this couple in preconception care.
So I think during this stage, you discover a lot of things. Through the screening, through the engagement with the mother, you discover a lot of challenges, complications, diseases. Are there some that can actually be reversed at that stage or before she actually conceives? Or are there some that then you'd have to manage while she's pregnant, because some may not go away? And what are those, and how would you go about it? How would the mother be supported with those kinds of scenarios? And you can give us some examples of some of those discoveries that you make during preconception.
Okay. So to be clear, it's not just the mother. So in preconception care, we want the couple.
Fantastic.
Because you can focus on the mother or the lady and screen her for things. She's fine, but you're not screening her partner. And then her partner, especially for infectious causes, will be the one to pass on. So it is the couple that we want to screen, we want to talk to, we want to have discussions with, but also because the partners are our social support. They are our main social support. So when they're part of this journey from the start, they understand the things we are talking about. They're not going to get these things that the doctor has told their wife from the wife, but they'll get it from from the health worker. It gives more weight when you have a couple. So it's important to have a couple. So are there things that can be reversed? Typically for things like infections or infectious causes. The best example we have in Uganda is the HIV infection. If you notice, there was a time when we had babies that were HIV positive. But then we had the PMTCT program start, and the government put in so much to see that women are on ARVs, that the HIV infection is managed, it is suppressed, and now we have a very low rate of transmission of HIV to babies because the women are suppressed. But we see that a woman who gets a new infection or the infection was never detected during her pregnancy, has a high risk of having a positive baby. So HIV is that example. But there are also other infections that children get other than HIV from their parents. Things like syphilis. Syphilis is an infection that we test for and we treat. Hepatitis B. If a mom has it, we want to see that it's well controlled, and we have interventions that we have to give the baby at birth to be sure that the baby is safe. So there's a classification called TORCH infections. So that is toxoplasmosis, not common, but there are babies that could get it from the mother. We treat the mother, but we treat the mother pre-conception. When she's pregnant, we may not treat because the drugs are toxic. We have infections like rubella, and I mentioned rubella has a vaccine, but still given before pregnancy. We have the CMV, which is cytomegalovirus, and HSV, which is herpes simplex virus. So those are infections, can be detected, can be treated, and the problems from those infections can be prevented.
Okay, fantastic.
Yes. When we look at things like hypertension and diabetes, these may not affect the baby per se, but mostly they will affect the mother in the course of the pregnancy. Like hypertension will give her a risk of preeclampsia. So when she has this before pregnancy, we give her medications to control the pressure, make sure her pressure is normal. Then she's able to have a normal pregnancy without spikes of blood pressure. But there are those that we may not be able to alter. Like when we screen for sickle cell disease and a couple, we have both partners are carriers. So we are not going to change their genetics because we screen them, they are both carriers. We can't change that. But we give them genetic counseling and we give them all the information that they need. They have to be aware that they have a 25% chance of having a child with sickle cell disease at every pregnancy, so that when they choose to go ahead and have children, they are aware of these risks. And also we show them the options.
So it's an informed choice.
It's an informed choice. There are also options of IVF for them, still informed choice, because that has expenses that come in. Still, we give them information. So there are those that we may change, there are those that we don't change. And then for couples that are older, we usually have to supplement for them folic acid. And here we are trying to see that we prevent neurotube defects. We are trying to prevent things like Down syndrome, but still Down syndrome is a genetic error. We may not be able to prevent it completely, but we can supplement mothers in their preconception time.
Okay, fantastic. We'll take a quick break and we'll be back with Dr. Emma to give us more insights into what her experience has been during this last few years of preconception care across the healthcare system. Welcome back to Voices. Dr. Emma, we've taken a deep dive into what preconception is all about. You've had a lot of experiences over the last few years doing this clinic. What stands out? What have you noticed? Is there a pattern? What are those things that stand out for you during these clinics over the last few years?
I have to think back and recall some of the encounters. Yeah, so I must say though, it's preconception care is not something that people in our general population think about so much. A number of women come for antenatal care themselves, because most of our partners are not really visiting as well. And when they come for antenatal care, then we discover, oh, you've been on this drug all this while. It's not safe for pregnancy. We've already gone 3 months into our pregnancy, and we can't change, that. So there are those instances where we find women in the antenatal care clinics, they're already pregnant, and whatever they've been on, whatever drugs they've been taking, medicines they've been taking, or whatever conditions they had, we didn't have a chance to make that better. And so we go through a pregnancy that is a high-risk pregnancy. Maybe their blood pressures keep fluctuating, they keep going up, and it's hard to control. Their blood sugars are way out of control, and we have limited options of the medicine types we can use when a woman is pregnant. But we've also had a few women who have been self-aware and have chosen to visit early and come and tell you, doctor, I want to get pregnant, but I'm hypertensive and I'm on these drugs. And so we start at that point. Yeah, so we are able to screen them and see how far along is the hypertension disturbing their body systems. With the physicians, we have goals of treatment. We change them to pregnancy-friendly medicines and make sure that those medicines are in doses that control their blood pressure. And by the time we get pregnant, we're not worried. And we go through those pregnancies smoothly because they are already controlled. We are not worried about their pressures, going up, or that they've been on some medicine that is unsafe. And we've had successful pregnancies like that. Same thing for women who are diabetic because they've been seeing their physicians and they've been managing them. And so when they want to get pregnant, their physicians have advised them, go visit an obstetrician, go visit your gyne. And those come in, and that's because they're aware, they're self-aware. But for majority of people, we don't really know that this is something that we can do. For women that are in HIV care settings, it's automatic, and the government and the development partners that support HIV care have really been so key in seeing that women are managed well, the women in reproductive age are managed for the infections, the touch infections. Some of them are also sexually transmitted infections. So they are treated for those, and that's why we've seen a drop in babies born with HIV. So that is really one of the classical examples of it working well. And so for these other infections, the touch infections that are sexually transmitted that are not HIV, are things that we can also catch for any other couple. The non-communicable diseases, those are things that we can manage and optimize, someone's health status before they also get pregnant. And you may say, so what about the men? What are we doing for them?
Well, you say it's a couple thing.
Yeah, it's a couple thing. So if we are screening the lady for infections, we're also going to screen the gentleman, because She may not have an infection, but maybe he does. And over time, he'll be able to pass it on to her. Like if it's a syphilis infection.
That will affect the baby.
Yeah, that will affect the baby in the long run. So we screen both and make sure they're both healthy. If any of them needs to be treated, we treat and make sure like the gentleman is not passing on something unintended, but that is possible. When it comes to genetic screening, we are screening both because the baby picks genes from mother and father.
True.
So because they're going to all give half the genetic material to the baby, so genetic screening is good for that too. But so overall, it's a chance to have a wellness check.
Yeah,
very many men fear the hospital, and they also fear to come for they also fear to come for antenatal care. So it's the chance to also know that you're fine and you're in good health state. So that is also very good for the men, I think. Yeah.
So as that's been very interesting. So being a new concept, in somewhat new, I know it's been happening over the years. At Nakasero Hospital, what are we doing to support this program to actually become or to have that impact that we wanted to have? What are those things that we have intentionally done or you have intentionally put in place to make sure that it actually succeeds and provides the right kind of impact?
Okay. First, we talk about preconception care. We talk about it in our clinics. We talk about it to our moms, even when they have delivered this baby and we are done with that pregnancy journey. We remind them that when they intend to have another baby 2 or 3 years later, it's important to have preconception care. So we create awareness to our moms, to our couples, and they know that this is something that we have. So we create awareness, just like we are talking about it today. So that's very important. And then we have a clinic dedicated to that. And we have a number of gynecologists and obstetricians that can provide this service to the women on that day. So we have a clinic day and we have the obs-gyn specialists available to give that service, to screen the couple, to talk with the couple and figure out the things that they need. We also have the screening modalities in the lab for the torch infections I talked about. Our lab is able to do that, to screen for toxoplasmosis, CMV, and so they're able to detect if you have it as a new infection or it's something you had before and it's now healed. So we are able to do that for you. We also have specialties that are not obs-gyn that may be required in your care. Like maybe we may need a physician because we found that you have hypertension or you have a kidney disease and we think we need a physician on board. So a physician will come on board and support you and see that, you're fine. For our, male partner, if we think you need maybe a physician as well or a urologist, we have those. So we are able to link you to other specialties of care that we think are important for you because we know much as we are doing for you preconception care, we've done for you a full workout and your health status. So if you think you need someone else to come on board, then we are able to call those for you. And we also have a vaccine center. So for vaccines that are important to be given preconception, we're able to give you those vaccines. And for these vaccines, we usually want them to be given at least 3 months before a pregnancy. And when one is pregnant, we mostly give tetanus, but things like rubella, influenza, we want to give them before. So we give those 3 months before, and those are also available.
Okay.
Yeah, just they're there around the clock.
So is this something that's running as a program? Is it part of my normal visit to the doctor? Is there some kind of dedication to it? Is there some kind of programming to it? Or is it just part and parcel of every day's visit to the doctor?
So we give it a specific day for the start, so that on that day we're really focused on that and create awareness. And as and when more people come, we probably will have more days dedicated to that. Why we are giving it a specific time and a specific day is because it's not the routine that where we are only seeing a woman that needs the guy. We are seeing the couple. So we want to give time to the couples to come and know like this is their time. So they come for a service in that time. So that we know that on this day we are serving 2 people, not having 1 person.
Okay.
Yeah, so yes.
So does every couple have the same tests? Or is there some kind of, through the history, you're able to knock off a few tests? Or do we have some kind of, is it the same test that every single couple does during this clinic? Or is it dependent on the history and maybe previous healthcare support they have gotten?
Well, I would say that some tests will be for everyone. Like when we are screening for infections, we're going to screen everyone, every couple that comes in. Because our country has sickle cell disease, that also we screen everyone. We are screening to know if you are carrier.
Regardless of the history.
Yeah, or not. Because you may not have sickle cell disease, but probably you may be a carrier. We don't know. So it will be a good thing to screen everyone. But there are some specific tests that may be depending on the history that we get. So in medicine, when we say history, we talk with you and ask you so many health questions about yourself. And those questions could guide us to things that we think we should check. So there may be some tests that may become important for me, but may not be important for another person, depending on my history, what I've been exposed to, where I work, or my family history. So some things may be relevant and some may not. But there are those that we run for everyone.
Fantastic. So, Dr. Emma, as we wrap up, it's been definitely a very good conversation. What advice would you give a couple out there? They've just gotten engaged. They are thinking of starting a family. What advice would you give? And it could also be a couple that has been a couple for a very long time, and they just think of having a child. They're not necessarily young. They could be in their 40s or 50s, and they've just gotten together and they want to have a child. What advice would you give that kind of couple?
But now you threw in the age of 40s and 50s.
30s, okay. 30s, 40s, 50s.
So for all, depending on the age range, there are different risks according to different age groups. So a couple that is between 20 to 30 may have different things that you're looking out for. They're probably younger. They may be trying out some drugs, recreational drugs. So they may have different, needs. A couple that is between 35 to 45 also have different unique challenges. At this point, we are worried more about congenital abnormalities because of the age of the couple. And so they're different things. So my advice to the couples out there that are intending to get a pregnancy, to have a child, is that visit the doctor. You can come visit us, visit the obstetricians and gynecologists, and have a conversation with them. We look out for risks that you may never know you have. So we look out for the risks that are possibly there. We look out for things that can be treated before that pregnancy starts. We give you the relevant vaccines you need before that pregnancy starts. We want to stop the culture of saying, oh, I wish you had come earlier. No, now let's come early and reduce the burden of congenital abnormalities. And if we are 40 and we're starting our family, we really want to have, we may not have as many children as the one that's already that's still 20 years. So the opportunities that we have to have a child should matter and should be successful opportunities. And that's what we want to have. We want to have a healthy mother and a healthy baby. Fantastic.
Dr. Emma, you've been fantastic. Thank you again for sharing your expertise. It's been a very lovely discussion. And we hope that you can join us another time. Please feel free to knock on our door and say, I want to have some more information to share with the world. To our listeners and our viewers, thank you for tuning in. I hope we have enlightened and your knowledge. I hope we have given you insights that will help you make the right choices as you move along. And for the couples out there, the team is here. The team is available to support you. The information is available. There is no reason why you should have a child with a condition that could have been prevented. The support is there. Walk into the hospital, ask for a gynecologist, ask about preconception care. You will get the support that you need. This podcast will go live. I will go out on all our platforms. Our viewers, follow us, check out our social media pages, Nakasero Hospital on all the platforms. We shall have it there. And every 2 weeks, we shall have a new podcast discussing the things that we find difficult in our healthcare space. Thank you for being a fantastic audience, and we hope to catch you next time. Thank you again, and see you next time.